months.
Okay, so we should be recording on Integrity. We have a brand new camera that hopefully will do much, much better for those online. So let's go ahead. So we are going to zip through the metastases, and then we're going to talk. Then we're going to do some potpourri from the beginning of the year, because we have hit everything, so you know everything.
So all diseases of mankind.
Okay. So here's our first one, and did you white balance and everything?
Yeah, you can. It's different software. So
it's different software.
Yeah, and it's on auto exposure, which
So it's auto exposure, and then do we have to choose an area for the white balance?
If you have white balance, you just do area white balance, and then you draw.
You're not having trouble.
I see. Okay.
Got it.
You're sarcastic.
There we go. Look at that. Okay. So, Dan, you want to start us out?
Sure. So, very interesting. This looks like a dermal process.
Yep.
There's quite a bit of smooth muscle in the superficial dermis, and there's appears to be a neoplasm with gland formation and some coalescence as well.
Yeah, so if you had big bundles of smooth muscle, you might think you were on the breast, and it could be primary.
Yeah.
In this chapter, we're not by and large dealing with the primaries. But
There seems to be a sense of maybe like a dirty necrosis or
dirty necrosis, so columnar epithelium, dirty necrosis goes with
colon cancer.
colon would be probably your top choice. How would you confirm it?
Well, CK20.
So keratin 20, what does keratin 20 tend to stain in terms of mets?
Colon particularly. And,
Yeah, if
they have like a diaphragm differential.
yeah,
of
exactly.
blood
If
that-
you want to make it easy, 7 is a smaller number than 20. 7 tends to be anything with origin above the diaphragm. 20 is a bigger, heavier number, so it's everything below the diaphragm in general. So 20 is below the diaphragm, 7's above the diaphragm. And then other more specific,
CDX2.
CDX2 is the one. There's an RCC for renal, there's CDX2 for colon, so there are a few more specific ones available, PSA for prostate. But to start the differential, we usually do 7 and 20, which is a roughly above and below the diaphragm type of differential. And that helps you narrow it down a little bit. This one is another adenocarcinoma. You can see the little microcystic pattern, little pattern of ducts throughout. This particular one was pancreas origin. It helps to have a little mnemonic, because you have a few that are either double positive or double negative with the keratin 20. So, having a little chart. But quite honestly, that's the sort of thing that you tend to look up. So, there are things that should be ready knowledge and things that you can look up. This is more something you look up in terms of what you need to memorize. The recognizable patterns that drive you in one direction or another are that's the ready knowledge that you should have for these. So that's what we're going to focus on, is some of those specific patterns. So this one, you have, Jessica, you want to?
Yeah, it looks like there's an infiltrate that some of the cells appear to sort of line up, which made me think of breast cancer and metastatic breast cancer.
Yeah, so you have large aggregates and smaller aggregates of cells that have a high nuclear to cytoplasmic ratio, have hyperchromasia, mitotic figures are present, the nests are very irregular in shape, they infiltrate between collagen, there's lumen formation, so it suggests that the whole thing is in fact adenocarcinoma. Let's get to that little lumen there. And then you commented that you do have some single file. Let's find some of those real nice areas, or real nasty areas, since I don't like this disease. You have some of these little single files between collagen bundles with nuclear molding present. That's very characteristic for breast, which is exactly what this is. And that would tend to be, because it's an above the diaphragm, it follows those general rules of 7 positive, 20 negative. James.
Yeah. Have just an unoriented chunk of cells,
What color would you call them?
like a blue-gray.
And are they particularly large, or are they more small blue cell tumor? So what's your small blue cell tumor differential? What do we normally think of in skin?
I mean,
The one that's in a trabecular pattern in skin with a smudgy chromatin pattern, yeah, is Merkel. But this also has a smudgy chromatin pattern and has small blue cells. It's not particularly a trabecular pattern, which is like a parallel theque, parallel wall or parallel row pattern.
could be the feared oat cell.
So the feared oat cell or small cell lung, any stains that would help you for that?
I'm sure there are.
So I want to jump in.
I know Merkel's.
TTF1, yeah. So thyroid transcription factor, one would think thyroid, which it does work for, but it also stains lung pretty reliably, including small cell lung. So when we have something that we suspect being Merkel in skin, in addition to the synaptophysin and the CK20 for the paranuclear dot, which is pair-A, which means next to, as opposed to pair-E, which means surrounding. I'm not sure how a dot can surround a nucleus. It would require multiple dots to be pair-E. So pair-A, nuclear dot, and synaptophysin, but then we usually throw in a TTF1 too. And what we're doing is ruling out lung with that. Other things, lymphoma, small cell endocrine, neuroblastomas, where you tend to get rosettes and carrot-like cells. Those are all things in the differential for the small blue cell tumor. Ewing's, PNET, neuroectodermal.
H helps narrow the differential.
I'm sorry, say it again.
H helps narrow the differential. Small round blue cell.
Okay,
The age of the patient.
Oh, the age of the patient helps. Yeah, that's absolutely true. Age of the patient does help. Merkel's tend to be in older people by and large. Okay. Other ones that are... More recognizable patterns, Christina?
So I don't think a lot of clearing out these cells. I know I don't seem to actually be clear enough for renal cell, but I know that's one where you think of like cleared vacuolated states.
And actually, they are clear enough.
Okay.
So things characteristic for renal, it tends to be usually a single round nodule. So a lot of the things we see like breasts tend to spread out and infiltrate between collagen. Renal tends to be a big round nodule, and that nodule is made up of tubules that have glycogen, so the cells appear clear, and then they are very bloody. There are lots of blood vessels with erythrocytes between those tubules. So we had one fellow who used to, in a British accent, say it was a bloody renal cell carcinoma, just to help the residents remember that they tend to be bloody and glycogenated. And then they're CD10 positive, and there's RCC and some other markers that can be used to confirm. But the skill set that would be appropriate for practice and sort of the at-hand knowledge you'd need for testing, etc., where you'd normally go, would be to recognize it on H&E, because you have to suspect it. That's the first step. So round to oval nodule, tubules of clear glycogenated cells, bloody, and that's about that. Okay. How about this one? Adam.
Well, not a whole lot to go on, but you see some basically epithelioid, large, atypical cells in the superficial dermis.
Any pattern where they are?
Pattern?
Yeah. You think they're just there within?
Lymphatic.
Within lymphatics.
So I was going to say squamous cell, but I don't know if you're leading me somewhere else.
Could be squam. I do see some little intracytoplasmic lumen formation here.
Okay. So thyroid.
The intralymphatic tends to be what kind of pattern of? Tone that pointer down just a bit there. Seems like the answer is no. So anyone want to jump in? Inflammatory. So that's inflammatory carcinoma. There are a few lymphocytes around. That has nothing to do with the name inflammatory. Inflammatory doesn't mean histologic inflammation. It means clinically it's pink to red. Looks kind of like erysipelas or cellulitis. And you will see it, and you will see it not uncommonly in practice. It is typically a worried 35 to 45-year-old woman who's post-mastectomy, and the breast is just kind of pinky red, and her surgeon's telling her it's nothing, it's okay, and she's worried, she knows it's something. If you biopsy and see only this, only dilated lymphatics, cut deeper sections to exhaust the block. If you don't find the tumor, biopsy again, because the likelihood is it's there. And she needs to know so she can get going with treatment. So, young woman, post-mastectomy, reddish, pinkish skin, just sort of subtly inflammatory looking clinically. That's inflammatory carcinoma, and you're going to see the nests of highly atypical cells lodged within the dermal lymphatics. Histologic inflammation has nothing to do with inflammatory carcinoma. It's clinical. And as I said, they can be very, very subtle. So this one was an atypical mole removed from a patient, and you can see it's kind of a Clark's-Nevis pattern. You got bridging of reedy shoulder, papillodermal fibrosis, so it's a Clark's-Nevis. You look down in the dermis, and it's riddled with inflammatory carcinoma, which was not suspected. So this was a good clinician who was going after a mole, did not really pay attention to the subtle erythema compared to the contralateral side. And you have within the dermal lymphatics all of that inflammatory carcinoma. Okay, David.
So, the diffuse infiltrated process, lots of clear, lobulated cells. There's like a renal cell.
Yeah, exactly. So this is, the last one was a small nodule. This is a big nodule, so you don't even see the sides of it. You just have a chunk of the big nodule. But again, it's clear glycogenated tubules, and there's a chicken wire pattern of vessels surrounding those tubules. That's typical for renal. And that allows you then to get a CD10 or an RCC. Just do the next step.
It's like they have in the mid-dermis, a columnar epithelium.
Yeah, it's definitely a columnar epithelium. And at the edge of the epithelium,
It's like it's ciliated.
yeah, either ciliated or decapitation. I mean, there's definitely something sloughing off the top there.
So maybe like signet ring or
Colon usually has dirty necrosis in the center, which means neutrophil type and necrotic nuclear debris. So it's pycnotic nuclei largely in the center, although you can see some neutrophil type inflammatory cells. So here you have a columnar epithelium, seems to have kind of a decapitation secretion thing going on. It has a stroma, and there's lots of red cell extravasation within the stroma. Anyone else want to jump in with what this may be? Endometriosis. And endometriosis is one of those things that simulates metastasis, so it's very important in the differential, and we see it not uncommonly in skin. So endometriosis, you're going to get a secretory columnar epithelium that looks almost apocrine because they're a little snouting or blebbing off the top. The key is then that stroma. It's often a concentric fibromyxoid stroma. You see that at the edge. It tends to be somewhat cellular. And then it has lots of erythrocyte extravasation, and if you flip down your condenser, you can often make out some refractile hemosiderin in there, because over time they get hemosiderosis from that red cell extravasation. So for the residents, that would be what you have to recognize, that pattern. For the fellows, you need to recognize the decidualized pattern, which looks completely different, but once you've seen it, you recognize it. There's a nice picture of each in the online lecture that goes with this, if you want to compare and contrast the two. Okay, Sean.
Okay, so this definitely looks kind of glandular. There's all these kind of lumens.
Yeah, and this is a belly button. And it's kind of a friable red belly button in a young person.
It's like a
Sister Mary Joseph nodule, maybe, but
So it's a young person, and I don't see any dirty necrosis, and I don't see any atypia.
Yeah, I don't look malignant.
So what would be a benign omphomesenteric polyp? So omphomesenteric polyp is what young people get. That's just ectopic gut epithelium in the belly button. And you're going to see a youngish person who has something that looks kind of like a Sister Mary Joseph nodule, this friable thing in the umbilicus. And when you biopsy it, it's benign gut epithelium. That's omphomesenteric duct polyp.
One little tooth down really deep.
Yeah, and that's about all you get, and it's right at the deep margin. Important lesson is sampling error is really big when you're looking for mets, and so biopsy deep enough, and biopsy again if there's a question, and step through the blocks. So. This one is kind of nondescript. It was clinically an inflammatory breast, CA. And it's, again, one of those where it's just really, really easy to miss. Okay, how about this one, Katie?
That stroma looks like endometriosis.
And that's exactly what it is. So the last one was a little one, and this is a great big one. And again, what's characteristic is you have that secretory columnar epithelium, surrounding it a fibromyxoid stroma, and usually some degree of red cell extravasation and or hemosiderin within that stroma. So it's a pattern recognition. Okay, who hasn't gotten to go yet? Okay, you want to grab one?
Sure. This looks like RCC to me.
Yep, absolutely. So again, you've got, this one is clear tubules with chicken wire vessels between them, looks like renal. And so it's just, the exercise for this is recognizing those basic patterns. So let's see, what else?
Looks like you've got adenocarcinoma of some sort.
Yep, adeno-CA, it's certainly tubular. There are large cells, high nuclear cytoplasmic ratio, but it's a columnar epithelium. It's a little bit, just a touch of dirty necrosis towards the center. Might make you suspect colon. And then colon is 20 positive and tends to be CDX2 positive. Let's see what else we got here. This one can be nondescript, and this one is kind of more nondescript. But sometimes you'll see yellowy bile in the cholangio. CAs. So, it's a big spectrum of how cholangiocarcinoma is going to show up.
What are the stains?
I'm sorry?
The stains that you do for that?
Usually you just start with a 7 and 20, and often, you can only get so far, and then it's imaging. But at least are you imaging above the waist? Are you imaging below the waist? Okay, this is a more typical colon. So big colon met, And, this one kind of defines dirty necrosis. In the center, you have large necrotic areas, and you see all that nuclear debris. So that's the characteristic dirty necrosis of a colon mat. In contrast, what's this one? Renal. Exactly. So clear tubules, bloody in between, that's a renal pattern. Just want to make sure. There were a few other choriocarcinoma pattern. You can see the large syncytial cells, but you can get choriodifferentiation in lung and other things as well. So, okay, how about this one? Looks like just a busy dermis, right? Almost like a dermatofibroma, but this would be the evil dermatofibroma. And when you look at the cells in the dermis, you can see hyperchromasia and very prominent nuclear molding. Instead of being round, they turn into squares and rectangles because there is nuclear molding where they're adjacent to one another. That is absolutely characteristic in this kind of fibrotic busy dermis for what pattern? Yeah, carcinoma on Cuirass, which is hard, woody induration of the chest in the setting of breast, CA. So again, my least favorite diagnosis because it kills a lot of young people. So this one, we have large anaplastic cells, but you also have these syncytial giant cells in the middle. That's what you see with choriodifferentiation. Just like you would see with syncytiotrophoblast, right? Placenta. So choriocarcinoma differentiation, it can be primary, it can actually be choriocarcinoma, or it can just be choriodifferentiation in another metastatic tumor. There will be HCG positive. So even if it's lung with choriodifferentiation, that'll be HCG positive. Okay, let us use the remaining time to do a little rapid fire potpourri because we've hit the basic patterns that we need for that. Okay, so we're going to go and kind of rapid fire. So, Ashley, you want to start us out?
Sure. So I'm seeing a predominantly dermal infiltrate of amphiphilic cells that are nests, and there's a lot of pigment extending deep that looks mainly like actual melanin. So
Okay, agree. And this part up
it's a
here,
bit of a junctional and maybe a little intralymphatic component. I don't know if that's going to be playing there. Yeah, so when you have pigment that deep, I mean, you're either thinking melanoma or some sort of blue nevus.
yeah. And what do you think about the nuclei of that central clone that's kind of gray?
It looks like a DPN.
Yeah, like a deep penetrating nevus. So
But since this is the junctional, you probably go combined. Oh, go ahead, sorry.
yeah, you're absolutely right. So we got a combined nevus where the outer part just looks like a banal nevus, and then you have the central nodule, which is surrounded by heavy melanophages. The nuclei are small, hyperchromatic, smudged nuclei, but they really are quite small. that's a deep penetrating nevus type of population. When that's a big nodule within an ordinary nevus, it's called common combined nevus of Reed, for Richard Reed from Tulane. Because at Tulane, where he had a largely referral practice of tough melanocytic lesions, this was the most common combined nevus that got sent to him, right? So that's why it's called common combined nevus of Reed. Okay, Tom. Another common combined nevus of Reed?
Probably not. We have a very broad melanocytic proliferation that has my hairs up for MIS at least, if not invasion, bronchitis spread.
So, you'd want to look at those cells in the dermis. To my eye, they're kind of bland.
Mm-hmm.
But you certainly have nests, and are the nests similar in size and shape?
No, there's some very small single units, and then you can't really have a single unit nest, but there's pleomorphism in the nest size.
Yeah, so there are areas where non-nested melanocytes probably predominate over nests. The nests themselves vary in size and shape, are not equidistant from one another. That's a little bit that looks like it's probably invasion. The red flat bottom fibrosis goes with melanoma in situ. It pushes the elastosis and all the elastic fibers down, bulldozing them away. The invasive melanoma is typically included within that bulldozing stroma. So if there's ever a question of whether that dermal component is melanoma or not, one of the things you can do is an elastic stain, because in invasive melanoma, the elastic fibers are bulldozed away. In most nevi, they're retained. In this case, you can just look at them because they look like the junctional population. They're larger, they have nucleoli. So it's a similar population cytologically, but sometimes it's more subtle and the elastic can help. Okay. Dan, do you see any atypia?
A lot of it.
Okay. And so what's your differential?
Squame.
Yeah, squame most likely because you see pink keratinization. So it comes off the epithelium and it's keratinizing in pink, so squame. So it's...
That's like really large, reedy.
Yeah, so big, large, reedy. So if it's a tumorous thing, it's not a tumor, it's not a cyst, it's an expansion of the epidermis, so we'd call that an acanthoma. Okay, so it's an oma, but it's an oma of acanthocytes, so it's an acanthoma. Does it look benign or malignant?
Looks benign.
Yeah, they look bland. And the cells are kind of spindly, so they're kind of spindled and whorled. So what kind of bland, spindled and whorled acanthomas do you get in skin? Anybody? So if there's duct differentiation, it's hydroacanthoma simplex, but they rarely ever spindle. So what loves to spindle in skin? Sebs. Yeah. So it's an irritated seb. Before you get squamous eddies, you get spindling. So it's really common. A spindled acanthoma is usually just a seb.
What are the two little? How come the ducts?
So you're looking at these little guys.
The bottom of the field.
Like there.
Yeah.
Yeah. If it is true duct, and you can always do a CEA, then that would suggest hydroacanthoma simplex. Given the spindling, my guess is that those are not going to decorate with CEA. And so why do you see those little pseudolumens in sebs? And they're really common in sebs. It's because hydroacanthoma simplex comes from the acrosyringium, sebs come from the periacrosyringeal keratinocyte. That's why they look so similar. It's just the cell next door. So it's that perisyringeal cuff of cells that gives rise to sebs. And then, if this has a couple of sebaceous glands that are probably not really part of the neoplasm, but if they're all through and really are part of the neoplasm, then it's got a stupid name that sounds like a description. It's reticulated acanthoma with sebaceous differentiation.
I was on the right track.
I mean, pretty much tells you what you're looking at, a reticulated acanthoma with sebaceous differentiation, but that's the name of the entity, too. Of Reed. Well, it's either of Reed or of Yadison, right? Isn't everything? Okay.
So it looks like you have these nested cells. You appear sort of nested. With a slight lichenoid infiltrate as well.
Yeah, so it kind of hugs the epithelium like a lichen of some kind. Is this a big broad lichen or a tiny little dot-like lichen?
Tiny little dot-like.
Can you think of any tiny little dot-like lichen?
Like a
nitidus, which tends to be a little ball and claw and one reedy and tends to have histiocytes and giant cells, whereas lichen planus only has lymphs. So histiocytes, giant cells go with lichen nitidus, whereas LP only has lymphocytes, and lichen nitidus tends to be small and dot-like, restricted to single little reedy.
As poro.
Porokeratosis. You've got your cornoid lamella right there at the edge, which you always look for. Well done, sir. Someone pass that easy button over.
Don't worry, you're busy. I'll hit it for you.
Okay. How about this one? So the orientation probably makes it a little harder, which makes it probably perform better. What does this little thing look like over here?
Like hair follicles.
Like hair
a mama
follicle.
And a baby, and I'm just missing the cut.
It's a mama and a baby in an oblique section.
Okay.
So this is big mama follicle, and these are all the little babies. They have an inner root sheath. They have papilla, so you know they are miniature but fully formed follicles. So if they're fully formed follicles forming follicular fibers, it's the folliculoma, right? So the trichofolliculoma is fully formed follicles forming follicular fibers, all entering into big mama. So mama and her babies. Whichever way helps you. You're very popular. Okay.
All right. Well, you got a pretty diffuse infiltrate slamming up against the epidermis here. They're not really spindle cells, but
They're
they
not
are
spindled, so
they're kind of amphiphilic.
Okay.
And
Anything else that they're doing?
Yeah, they have two-ton giant cells. So
They have two-ton giant cells, which means wreath giant cells with lipid peripheral to the wreath.
right. So it makes me think of an XG.
A xanthogranuloma. The two-tone cytoplasm, rosier and paler cytoplasm goes with either a Spitz or a histiocytic type cell, In this case, you see Teuton giant cells, which are wreath giant cells with lipid peripheral to the wreath, and that would be typical for a xanthogranuloma. They usually tend to be, here they're in the center, usually they're at the top and the bottom. They're usually at the periphery. Xanthogranulomas start with just sheets of gray histiocytes, then wreath giant cells form at the periphery, then they lipidize. That's kind of the life of an XG. You can say JXG if your patient is J, but your patient isn't always juvenile, so then it's just a xanthogranuloma. So if your patient's not J, it's just an XG.
J at heart.
Many of us are J at heart.
Let's see, so there's some acanthosis, some of the horn, there's some perikeratosis, maybe some serum crust. Lots of atypia, let's say, in the epidermis. Maybe some pagetoid spread.
So you definitely have some cells that are up high. Someone want to describe, what do you think about that cell?
Maybe that's more a dead keratinocyte.
So
there's an acantholysis, maybe.
There's acantholysis. It's round, and it's surrounded by a clear rim. So it's acantholytic. Is it just acantholytic, or is it also dyskeratotic? So there's acantholytic dyskeratosis, and there is suprabasilar clefting, giving villi. So you've got villi, and you've got corons. So what are you thinking?
Looks kind of focal, maybe like a warty dyskeratoma.
Yeah, if it's one solitary lesion, it's warty dyskeratoma. If it's little crusty red things over the chest and back of an old guy, it's Grover's. If it's isolated to the vulvocrural area, it's the isolated vulvocrural acantholytic dyskeratosis, which is common in both kids and adults. And that's actually what that one was. Let's see. Trying to pick out ones that are really good. Okay, so I'm looking all the way across, and all I see is this one little focus of that.
Looks like we kind of have a thin epidermis, and just deep to that is a cluster of pigment-producing cells.
So, do you think it's likely that this is pigment-producing or pigment that dropped out of the junction? Yeah. So more likely pigment incontinence, and pigment incontinence surrounding little pink chunks. So what's your differential for the little pink chunks?
Like like a Savat body.
So they could be Savat bodies, or they could be amyloid. So, it's either going to be a lichen or macular amyloid, or a little focal lichenoid process. It would be very, very rare to see Savat bodies in lichen nitidus. That's a granulomatous process, rarely has Savat bodies. This was labeled lichen nitidus. I would change that on the label.
Tissue here. See these nodular aggregates of infiltrating cells that kind of palisade at the periphery.
Yeah.
It's like lymphadenoma.
So kind of lymphadenoma, except that the center is not lymphs and histiocytes.
Okay.
Right?
Mm-hmm.
But your stroma has big plump mesenchymal cells, which are your papillary mesenchymal bodies, and it's a concentric fibroblast-rich stroma with clefting within the stroma. So it looks like a pilar fiber sheath. So what would be a big benign pilar oma that's not a basal cell?
Pilar sheath acantoma or trichoepithelioma?
Or trichoepitheliomas are the better differentiated trichoblastomas. So the big category is trichoblastoma, and then your well-differentiated ones are the trichoeps. That's a superficial, well-differentiating, often keratinizing trichoblastoma as a trichoep. Careful if this is an old person. You get off to the edge, and it really looks a little like superficial multifocal BCC, and there's heavy elastosis. You can have basals that are very well differentiated and simulate trichoblastomas. So careful of solitary growing lesions in old people. I doubt that's a trichoblastoma. I think that's probably a well differentiated basal cell. Let's see. We're almost where we have to end. So let's do a couple here.
So, definitely looks malignant or angulated islands.
So angulated islands. Tell me about the stroma.
It's really dense and sclerotic.
Yeah, almost looks like it has little.
Like bone.
It looks almost bone-like. It's an osteoid-like stroma, and then the tumor itself has clear cell change and has duct filled with the bright red stuff. What's that?
Acrosyndrome type?
Yeah, sweat. So this is a sweaty tumor with an osteoid-like stroma. What's a sweaty tumor with an osteoid-like stroma?
I mean, a lot of times if you have a myxoid cyst that has cartilaginous stroma, but I haven't seen bone.
Any fellows you want to weigh in?
Chondroid syndrome.
So
Just osteoid syndrome.
chondroid sarcoma, but if this is not actually bone, that's actually a million layers of basement membrane zone forming that osteoid. Just acrosporoma, benign poroma. That tumor has lots of names: acrosporoma, clear cell hydranoma, solid and cystic poroma. Anything that's a hydranoma, a poroma, or an acrosporoma, they're all in the same family. And what they have in common is they tend to do clear cell change. They tend to be sweaty, so they have ducts filled with sweat. And they have this osteoid-like stroma that is so characteristic, it's often called poroma stroma. So recognize that poroma stroma because it's a big gift. Then you're going to look at the periphery. It's a big nodule, but it's not really infiltrative. The whole thing, despite its size, is probably a completely benign poroma because that stroma is throughout, and that stroma suggests chronicity. It takes time to get that million layers of basement membrane zone. Infiltrative porocarcinomas, if any of that stroma is retained, it's retained in the old bit that was the poroma that it arose from. Here, it's part of the tumor all through. It tells you this whole thing's big but benign. So just a big sweaty poroma with that characteristic poroma stroma. You getting kicked?
No, I think I said myxoid. I meant mixed. I'm blaming it on the pregnancy brain.
Oh, the pregnancy. Well, yeah, all your blood is getting sucked to the fetus. So. Okay. So,
seems like
Sure.
a logical lesson. You and her.
So it looks like there's a superficial infiltrate, predominantly lymphocytic, maybe some histiocytes as well. So.
And is there anything at the junction happening?
It looks like there is some mild interface.
Yeah, just a little bit of interface. And is it lots of sites of damage out of proportion to lymphs, or is it sparse but a lymph in every hole?
Sparse but a lymph in every hole.
And tell me your differential for a lymph in every hole.
So I think that like PLEVA or PLC.
So PLEVA and PLC, and there's a little red cell extravasation, which might suggest PLEVA or PLC.
PR, I think.
That's spongiotic.
Spongiotic, sorry. MF.
MF.
So that's what I would think about.
Also early evolving stage of a benign lichen keratosis can be lymph in every hole. Syphilis can be lymph in every hole. That's about it for the list. It sounds like Forrest Gump. That's about it. What?
Can GVHD look like this at all?
No. So GVHD is sites of damage out of proportion to lymphs. This one, you see bundled collagen above the postcapillary venial. That counts as papillodermal fibrosis. That puts you strongly towards MF. So a lymph in every hole pattern with papillodermal fibrosis is MF till proven otherwise. And with that, we're right at the hour, and we're going to stop.
Thank you.
Thank you.
Thank you for. Yeah.